The subcommittee will come to order. The chair will recognize himself for 5 minutes for an opening statement. Today's legislative hearing will focus on H.R. 2405, the Pandemic and All Hazards Preparedness Act of 2011, H.R. 1254, the Synthetic Drug Control Act of 2011, and the Enhancing Disease Coordination Activities Act of 2011. Our witness for the first panel will be my friend and fellow Pennsylvanian Representative Charlie Dent. His bill, H.R. 1254, the Synthetic Drug Control Act, addresses a growing problem in many states and gives law enforcement additional tools to deal with the very real dangers of synthetic drugs. H.R. 1254 would prohibit the sale of synthetic drugs that imitate the hallucinogenic and stimulant properties of drugs like marijuana, cocaine, and methamphetamines. While these drugs are synthetic, they are just as dangerous as the real thing, but they are not illegal. Along with banning these synthetic drugs, the bill would also allow the Drug Enforcement Administration, DEA, to temporarily schedule a new substance for up to 3 years instead of the current standard of up to 18 months. Next, the subcommittee will examine Representative Rogers' bill, H.R. 2405, the Pandemic and All Hazards Preparedness Act of 2011, which would reauthorize certain provisions of the Project BioShield Act of 2004 and Pandemic and All Hazardous Preparedness Act of 2006. These laws help protect our country against pandemics and attacks from chemical, biological, radiological, and nuclear weapons. Among the reauthorizations in the bill are the Biomedical Advanced Research and Development Authority, BARDA, which helps to ensure that early-stage research leads to tangible medical countermeasures that can be used to save lives in an emergency, and the reauthorization of Project BioShield Special Reserve Fund, which helps procure medical countermeasures against anthrax, smallpox, botulism, and other threats for the Strategic National Stockpile. Finally, the Enhancing Disease Coordination Activities Act of 2011 would allow the Secretary of Health and Human Services to establish committees based on existing interagency coordinating models that will help coordinate disease-specific research and other activities currently spread across the Department. I would like to thank all of our witnesses today, and I'd like to yield the remainder of my time to Representative Rogers from Michigan.
Thank you, Mr. Chairman, and for holding this very important hearing. Last month I introduced H.R. 2405, legislation to reauthorize the Pandemic All Hazards Preparedness Act. I want to thank Gene Green and Sue Myrick for being original co-sponsors on this bill, which will also reauthorize Project BioShield's Special Reserve Fund. It's been almost 10 years since 9/11 and the anthrax attacks that followed. And while we haven't had a successful terrorist attack in U.S. soil, our enemies are still working every single day to kill innocent Americans. Bioterrorism remains a very real threat to our country, which is why I think this bipartisan legislation is so important. Over the last 10 years, we've made significant progress in our ability to protect the public from CBRN threats. Congress created Project BioShield in 2004, creating a market guarantee that prompted the private sector to develop countermeasures for the federal government. In 2006, we also created the Biomedical Advanced Research and Development Authority, BARDA, which helped bridge the valley of death that prevented many countermeasure developers from being successful. Today, we have numerous vaccines and treatments in the Strategic National Stockpile that will save lives in the event of an attack. While we hope that we never have to use these medical countermeasures, they are essential to protecting the public health from a bioterrorism attack. Simply put, we must always be prepared. I'd also like to thank Mr. Pallone and Mr. Waxman for working with us on this bipartisan basis to move this legislation through the committee. The issue has always been a bipartisan effort, and I appreciate their willingness to partner with us. I also look forward to hearing from Dr. Nicole Lurie, the HHS Assistant Secretary for Preparedness and Response, who oversees the entire medical countermeasure enterprise. It's an important role in protecting the country, and I'm pleased that they have also worked with us on this critical legislation. Thank you again for holding this hearing, Mr. Chairman. I yield back my time.
Chair, thanks to the gentleman, and ask unanimous consent to enter the statement of Joe Ranazizi of the Drug Enforcement Administration into the record? Without objection, so ordered. The chair recognizes the ranking member of the subcommittee, Mr. Pallone, for 5 minutes for opening statement.
Thank you, Chairman Pitts, and thank you for holding today's hearing on these important health bills. I'm encouraged that this hearing marks 2 bipartisan hearings in a row for the subcommittee, and I support all 3 bills under consideration, and I thank our witnesses for joining us today. Over the past 10 years, this Congress, rightfully so, has placed a high priority on biodefense. In 2004, we passed the Project BioShield Act with tremendous bipartisan support. Democrats and Republicans worked together to establish a process that would help our nation respond to bioterrorism threats and attacks. Its goal was to encourage the development of new bioterrorism countermeasures. Unfortunately, at first, the program had limited success. This committee recognized its shortfalls and in 2006 worked to amend the program to help fix some of the problems. Specifically, it provided the Department of Health and Human Services with the additional authorities and resources necessary to rapidly develop drugs and vaccines to protect citizens from deliberate, accidental, and natural medical incidents involving biological pathogens, as well as chemical and radiological agents. It also helped to build the nation's health infrastructure. In addition, a single point of authority within HHS was created for the advanced research and development of medical countermeasures to quickly make important procurement decisions. The new position of Assistant Secretary for Preparedness and Response, ASPR, has since led the federal government's effort. And today we consider H.R. 2405, the Pandemic and All Hazards Preparedness Act of 2011, which attempts to further strengthen these programs. Specifically, it clarifies ASPR's role in these efforts and attempts to improve coordination and accountability. We've worked very closely with the Republicans on this bill, and while there are still some minor outstanding issues, I'm confident they can be settled. I know some of my colleagues also have issues they'd like to see addressed, specifically the ways in which we can enhance the nation's ability to care for pediatric populations and the critically ill or injured in the event of a public health emergency, and I hope we can incorporate these important ideas in some way into the reauthorization bill. Another bill we're considering today is the Synthetic Drug Control Act, introduced by Representative Charles Dent, who joins us today. It's quite alarming to hear some of the stories you've shared, as well as other members whose constituents have been able to utilize these products to the detriment of their mental and physical health, and in some cases costing them their lives. It appears these imitation drugs are not illegal, and I support strengthening the federal government's ability to keep these harmful and dangerous drugs off the street. Lastly, we're discussing the Enhancing Disease Coordination Activities Act of 2011. This year, HHS is devoting over $900 million and 72,000 full-time employees to carrying out their mission, and I quote, to help provide the building blocks that Americans need to live healthy, successful lives. As such, tackling the countless diseases we face is a major component of their work. For a large and complex organization with an even greater charge, the flexibility to form coordinating bodies to better organize research and public health activities is ideal. The committee recently considered the Combating Autism Reauthorization Act of 2011, a bill that seeks to address autism spectrum disorders, a major public health problem in New Jersey and across the nation. The original program created the Interagency Autism Coordinating Committee, which, as we heard last week, has been largely successful. So I'm encouraged that it can and should serve as a model for the creation of other disease-specific coordinating committees. The Enhancing Disease Coordination Activities Act of 2011 will give the Secretary explicit authority to create committees that would not only streamline activities within the department, but also would stimulate partnerships between public and private organizations. Especially at a time when we're faced with such limited resources, coordinating activities across public and private sectors is critical. So I look forward to working with you, Chairman Pitts, as we move on these critical pieces of legislation through this committee into the House floor. And I'd now like to yield what time I have left to Ms. Baldwin.
Thank you. I want to thank you, Mr. Chairman, and Ranking Member Pallone for holding this important hearing on bipartisan measures that focus on our nation's public health preparedness. I'm not going to be able to offer my entire opening statement, so I ask unanimous consent to insert that for the record in its entirety.
Without objection, so ordered.
Thank you. But I did want to point out that earlier this year I introduced a bipartisan bill called the Critical Care Assessment and Improvement Act with my colleague from Minnesota, Eric Paulson. The bill seeks to identify gaps in the current critical care delivery model and bolster our capabilities to meet future demands. I am hopeful that we will be able to incorporate some of the relevant provisions of that act into the Pandemic and All Hazards Preparedness Act as we look towards that reauthorization. And in that vein, I look forward to working with my colleagues on both sides of the aisle to do so as this legislation moves forward. Again, Mr. Chairman and Mr. Pallone, thank you so much for holding this bipartisan hearing. I yield back.
Chair, thanks, gentlelady. Now recognize the chairman of the full committee, Mr. Upton, for 5 minutes.
Well, thank you, Mr. Chairman. And first, I want to congratulate you and your wife on 50 years of bliss tomorrow. Formally 50 years. Yeah. I also want to thank you for holding today's hearing on bioterrorism, controlled substances, and public health legislation. I look forward to hearing from the witnesses on these important pieces of legislation, particularly our good friend, Mr. Dent of Pennsylvania. Congressman Mike Rogers, the good Mike Rogers, recently introduced H.R. 2405, the Pandemic and All Hazards Preparedness Act of 2011. This bill reauthorizes provisions of the Project BioShield Act of 04 and the Pandemic and All Hazards Preparedness Act of 06, laws we passed in the wake of September 11th to build the nation's health infrastructure and foster the development of medical countermeasures so the nation could better respond to terrorist attack. Congressman Dent introduced H.R. 1254, the Synthetic Drug Control Act, to prohibit the sale of synthetic drugs that imitate the effects of drugs like marijuana, cocaine, and other methamphetamines. These synthetic drugs are certainly just as harmful and dangerous as those drugs, but due to a loophole in the law, they are not illegal. This bill solves that problem. Finally, the Enhancing Disease Coordination Activities Act of 2011 would improve the coordination of research and other activities conducted or supported by HHS. Inspired by the success of the Interagency Autism Coordinating Committee, the bill would allow the HHS Secretary to establish committees that coordinate research and other activities on specific diseases and conditions. The bill also would enable HHS Secretary to conduct a review of existing disease-specific committees at HHS to determine the benefits of maintaining them. So, as I said at last week's hearing, we must find a way to have our agencies work better together with a common strategic vision, and I think these bills do that. I yield the balance of my time to Dr. Burgess.
I thank the chairman for yielding. I appreciate the fact we're having a legislative hearing, and certainly I hope the committee will move expeditiously on all three. Let me comment, because of the briefness of the time, on the Pandemic and All Hazards Preparedness Act of 2011. This program was launched after the terrorist attacks in 2001 and set the framework for new medical countermeasures to respond to any attacks in the future. This program encourages and spurs market entry and competition and ingenuity into the private market. In the aftermath of an attack, we need to be assured that there is an adequate supply of countermeasures for the strategic national stockpile, and this program helps to accomplish that goal. I certainly want to thank Congressman Rogers from Michigan for his hard work on this legislation, for his willingness to walk through the shadow of the valley of death, literally, and move this bill along. I also want to thank him for his inclusion of H.R. 570, the Dental Emergency Responders Act, which provides clear authority for dental professionals to participate in supporting medical and public health measures in response to disasters. So I certainly look forward to working with the chairman and to Mr. Rogers on this bill, and see that the passage of H.R. 2405 as well as the other bills before us. I'll be happy to yield any time I have remaining to any other member on the Republican side who wishes to comment for an opening statement. If not, Mr. Chairman, I'll yield back to you.
The chair thanks gentlemen, and now recognizes the ranking member of the full committee, Mr. Waxman, for 5 minutes.
Thank you, Mr. Chairman, for holding today's hearing on three important pieces of public health legislation: H.R. 2405, the Pandemic and All Hazards Preparedness Reauthorization Act of 2011, H.R. 1254, the Synthetic Controlled Drug Act of 2011, and the soon-to-be-introduced Enhancing Disease Coordination Activities Act of 2011. I'm pleased that we have once again come together on a bipartisan basis to move forward with these bills. Although our work is not quite complete, I feel confident that we'll work out the substance of these bills through further discussion. I want to thank you, Mr. Chairman, and your staff, as well as all the members of the subcommittee, for working with us to make this happen. This bipartisan approach has been the foundation upon which each of the proposals we'll discuss today have been developed. The Pandemic All Hazards and Preparedness Reauthorization Act reauthorizes programs and activities first established in the 2004 Project BioShield Act. These programs are critically important to help ensure that our nation is well prepared to successfully manage the effects of natural disasters, infectious disease outbreaks, and acts of bioterrorism. In reauthorizing these programs and activities, there are a number of issues we're exploring and would like to hear about during today's hearing. In my view, surge capacity, the ability of our healthcare system to respond to mass casualty emergencies and biosurveillance, the ability to detect natural or man-made hazardous or disastrous events as soon as possible deserves special attention. So does the state and local public health infrastructure needed to support these kinds of efforts. The role of the FDA in dealing with various public health emergencies of great enormity is especially critical. I have concerns about the new regulatory management plan that is proposed in 2405, but I believe we can achieve the balance necessary to make certain that the communications process functions as it should. On the one hand, allowing FDA the flexibility it needs to deal with regulatory science issues of great complexity on the other. We should also consider the idea of allocating some of the BioShield funds to FDA in support of its countermeasure review process. This approach would allow FDA's work to complement the efforts of both NIH and BARDA. Clearly, we cannot permit resource constraints to stand in the way of FDA's ability to complete its reviews, putting in potential jeopardy the entire BioShield enterprise. Other subjects we'd want to look at include the unique needs of children in disasters, an issue that Congresswoman Eshoo has been championing, the administration's strategic investor proposal, and like the other issues I've just mentioned, I'm confident that all these matters will be resolved in a bipartisan negotiation. Let me now speak briefly about the two other bills that are under hearing today. The Synthetic Drug Control Act adds specified synthetic versions of drugs of abuse to Schedule I. These designer drugs can be very unsafe, causing convulsions, anxiety attacks, and dangerously elevated heart rates, among other conditions. This bill would enable the Drug Enforcement Agency to take appropriate enforcement actions to get them off the street and away from our nation's youth. Finally, the Enhancing Disease Coordination Activities Act provides direct authority to the Secretary of HHS to establish disease-specific interagency coordination committees and lays out the parameters for these committees. This will be modeled on the highly successful Interagency Autism Coordinating Committee, which we learned about in last week's hearing. Again, I want to thank you, Mr. Chairman, and the members of the subcommittee for cooperation with which we've worked on all three bills under consideration. I look forward to the hearing today and to working out our issues. And I have less than a minute if anybody on our side would like a minute. If not, I yield back the time.
Chair, thanks, gentlemen. That concludes the members' opening statements. I'd like to thank all the witnesses on both panels for agreeing to appear before the committee today. We'll go to panel one. Congressman Charlie Dent represents Pennsylvania's 15th Congressional District. He's the author of H.R. 1254, the Synthetic Drug Control Act. Representative Dent, you may begin your prepared testimony.
First, I want to thank the committee and the subcommittee. Thank you, Chairman Pitts, Ranking Member Pallone, Chairman Upton, Ranking Member Waxman, for this opportunity to talk to you today about this very important issue. It was a little under a year ago this time that the issue of synthetic drugs or designer drugs was first brought to my attention by a constituent named Luana Marshall, whose son had been abusing legal substitutes or legal substitutes for marijuana. In fact, just a couple of months ago, I went to the Children's Hospital of Philadelphia, where they had seen very little of these issues in synthetic drugs, bath salts, etc. And now they're seeing a case every single day. That's how prevalent this has become in such a very short period of time. These synthetic cannabinoids affect the brain in a manner similar to marijuana, but they can actually be much more harmful. Synthetic marijuana or cannabinoids are just one category of designer drugs. Even more potent substances have properties similar to cocaine, methamphetamine, LSD, and other hard street drugs. These substances are marketed as innocent products like bath salts, plant food, incense, and they are sold under brand names familiar to their users, such as K2 Spice, Vanilla Sky, Ivory Wave, but these are total misnomers. They're designed to facilitate their legal sale. These drugs have really no legitimate purpose. And these bath salts, by the way, are things you would never put in your tub. Some people are confused by that. They actually think they're what people put in the tub. That's not the case at all. Over the past year, there's been a sharp increase in the number of reports detailing horrific stories of individuals high on synthetic drugs. A man in Scranton, Pennsylvania, stabbed a priest, and another jumped out a three-story window. Both were high on bath salts. Several deaths from West Virginia to Florida have been attributed to overdoses of synthetic drugs. Senator Grassley of Iowa has introduced a bill with provisions similar to the one in this one, H.R. 1254, named after one of his young constituents who tragically took his own life while high on synthetic marijuana. A man in my district was arrested this past May for firing a gun out a window in a university neighborhood. The police charges indicate that the individual injected himself with bath salts, and he later told police he thought there were people on the roof watching him. Finally, I was approached by another distraught mother from my district whose son was hospitalized for over 2 weeks after suffering liver failure and other complications after injecting himself with bath salts. These substances pose a substantial risk, both to the physical health of the user as well as to the safety of those around them when these drugs contribute to dangerous psychotic behavior, suicide, and public endangerment. The fact that these drugs are legal in many states contributes to the misconception that they're safe. And the use of these easily recognizable brand names and logos on the packaging promotes the concept of a consistent product. Significant variation of potency from one unit to the next has led recurrent users to inadvertently overdose. One of the major difficulties in combating these designer drugs is the ability of the producers to skirt the law with different chemical variations. By modifying the formula in some minor way, producers can generate a new compound which circumvents legal prohibitions but has similar narcotic events. And that's why we have H.R. 1254, the Synthetic Drug Control Act of 2011, and we drafted this in consultation with federal law enforcement officials, particularly at DEA. And this legislation has three principal components: prohibition of broad structural classes of synthetic marijuana or the cannabinoids, prohibition of other designer drugs such as bath salts, that's mephedrone, MDPV, and others, and there's an expansion of the DEA's authority, or existing authority, to temporarily ban a substance from 1.5 to 3 years, and that's very, very significant, that additional time. Under current law, if the DEA and the Department of HHS can prove that a substance is dangerous, that's important. But they also are lacking in legitimate value while it's temporarily banned. So the prohibition becomes extremely important. I can't emphasize that enough. This authority for DEA. I should mention too that there are a lot of states out there right now that have passed laws. Pennsylvania, my state, just passed a law in the last month that have banned many forms of these synthetic drugs. But federal action is certainly necessary to prevent these drugs from being obtained by simply crossing state lines or increasingly ordering them over the Internet. And I think every state represented on this panel, except Ohio, but Representative Latta will fix that, has enacted laws restricting some synthetic drugs in one form or another. So all your states have already taken some action, and that's you're being commended. So Texas, Michigan, Kentucky, New Jersey, Illinois, New York, North Carolina, Georgia, Wisconsin, Washington State, they're all really taking some action. Louisiana, Arkansas, Utah. So state-by-state differences in which individual substances are controlled and how strongly makes for a confusing legal patchwork, and this bill will provide for a national ban on these dangerous drugs. As we speak, the Senate Judiciary Committee right now is marking up a companion synthetic drug legislation, and so I really would encourage this subcommittee and then the full committee to take up H.R. 1254 as soon as possible and report it. You'll really appreciate this. This is a very serious public health issue, and it's just getting worse by the day. These drugs come into this country, usually via Europe, start in Asia, they head to Europe, so we usually have a good idea of what's coming here. DEA is on top of this, but they really do need this additional authority. And again, I appreciate your consideration. Thank you again, Chairman Pitts, Ranking Member Pallone.
Chair thanks the gentleman for his testimony. Thanks him for his leadership on the issue. We look forward to working with you on the legislation. And you may be excused at this time, and we'll call panel 2 to the witness table. Our second panel consists of 2 witnesses. Dr. Nicole Lurie is the Assistant Secretary for Preparedness and Response of the Department of Health and Human Services. And our second witness, Dr. Howard Koh, is the Assistant Secretary for Health of the Department of Health and Human Services. Thank you for coming this morning. Dr. Lurie, you may begin your testimony.
Good morning, Chairman Pitts and Ranking Member Pallone and distinguished members of the subcommittee. In 2006, the Congress understood the critical need to strengthen our public health and medical preparedness activities, enacting the Pandemic and All Hazards Preparedness Act, or PAPA, as it's affectionately known. Recent events remind us of the significant challenges that we continue to face, from ever-present and always evolving terrorist threats to unprecedented natural emergencies, and how quickly and unpredictably the call comes to respond and support the American people. Within HHS, PAPA established the Assistant Secretary for Preparedness and Response as the lead in coordinating federal health response to disasters. In 2009, I had the privilege of being asked to lead ASPR, a still young organization with a vital mission to lead the country in preparing for, responding to, and recovering from the adverse health effects of emergencies and disasters. And since that time, ASPR has risen to the challenge in the face of unprecedented events. As we responded, capturing lessons learned along the way, we kept careful note of where legislative changes would enhance our response to efforts in the future. I'd like to take a few minutes now to walk you through some of them. The H1N1 pandemic tested our ability to adapt and respond to a novel influenza strain, and required all parts of the healthcare, public health, and response systems to work together and to innovate. One of the most important lessons learned came from seeing that at every step along the way, we needed to be able to rapidly get resources to where they needed to go. Consequently, we're interested in authority to temporarily allow states to reassign certain HHS-funded personnel to critical areas of need during a public health emergency. Both H1N1 and the Japanese nuclear crisis demonstrated the importance of getting countermeasures to those who need them as quickly as possible. Often, the speed with which countermeasures are administered is the difference between life and death, and so we would like the authority to issue emergency use authorizations, or EUAs, prior to an event. This would minimize delays in making critical countermeasures available when needed. In addition, clarifying FDA's authorities to extend the timeline for safe and effective products through the Shelf Life Extension Program will facilitate using these products when needed and will make investments go further, helping save taxpayer dollars on replacement costs and stockpiling practices. We've been successful in developing promising safe and effective medical countermeasures, and the BioShield program has indeed been a critical tool. As demonstrated by the language included in H.R. 2405, your continued support to this program is a clear commitment to the nation's preparedness. I want to highlight that we embrace the whole community approach articulated by FEMA, particularly in planning for all at-risk individuals. In the countermeasure arena, we have become very aggressive about pursuing medical countermeasure products for children. The Secretary's Medical Countermeasure Enterprise Review recognized that to achieve a modern and flexible enterprise that can quickly develop and produce safe and effective products, we must strengthen each of the enterprise's major components. One recommendation, the Strategic Investor Initiative, will support and accelerate the activities of companies that have innovative products while reducing the probability that the companies will fail because of their inability to manage their business risks. H.R. 2405 reauthorizes 2 critical elements of our preparedness enterprise, the Hospital Preparedness and the Public Health Emergency Preparedness Cooperative Agreement programs. When I visited Missouri after Joplin and witnessed the ongoing response and recovery efforts from the tornadoes in May, and similarly with the tornadoes in the South before that, it was again clear to me why we need both medical care and public health capabilities. A central priority for me is the alignment of these two programs, as well as similar grant programs throughout the government, to efficiently use limited resources, eliminate duplicative or conflicting programmatic guidance, and reduce the administrative burden for grantees. We anticipate that the FEP and HPP programs will be aligned in time for the 2012 grant guidance. Reauthorizing other programs, including BARDA, the Medical Reserve Corps, the National Disaster Medical System, and the Emergency System for the Advanced Registration of Volunteer Healthcare Personnel, will ensure investments continue to support and foster resilient communities. As identified in the original PAPA legislation, HHS, and specifically ASPR, has the lead for coordinating the federal health response efforts during public health emergencies. In my time as serving as Assistant Secretary, ASPR has strengthened its leadership role within HHS as well as nationally. Along with our federal partners, we've improved our coordination of preparedness and response operations, and we've also gotten better at how we coordinate. Our continued progress and improvements, along with clarifying and strengthening authorities that I've talked about today, will ensure ASPR and HHS have the tools necessary to protect the nation against public health threats. We applaud Congress's leadership and vision for enacting PAPA as the foundation for effective response and recovery to public health emergencies, and I look forward to working with you as PAPA is reauthorized in this congressional session. Thank you.
Chair, thanks, gentlelady. Dr. Koh, you're recognized for opening statement.
Thank you very much, Chairman Pitts, Ranking Member Pallone, and distinguished members of the committee. I'm Dr. Howard Koh, the Assistant Secretary for Health for HHS, and I'm very pleased to be here to testify in the legislation entitled Enhancing Disease Coordination Activities Act of 2011. As the Assistant Secretary for Health, I have the honor of overseeing some 14 core public health offices, 10 regional health administrators and their staffs, and 10 secretarial and presidential advisory committees. Collectively, our Office of the Assistant Secretary for Health implements an array of interdisciplinary programs relating to ensuring the nation's public health. And in fact, our portfolio includes programs in many areas such as disease prevention, health promotion, women's health, minority health, adolescent health, vaccines, fitness, sports and nutrition, human research protection, among other areas. The mission statement of our office, in fact, is, quote, mobilizing leadership in science and prevention for a healthier nation, unquote. We're very proud of this mission, and we're very proud of the efforts of the Department and all public health colleagues, in fact, in helping all Americans reach their highest attainable standard of health. So in that context, I'm very pleased to add some comments about the draft legislation here before us to improve the coordination of research and other activities conducted or supported by HHS that are specific to a disease or condition. I thought it would be useful to share our experience in coordination efforts at HHS because over recent months, our office has helped put forward strategic plans and coordination in a number of areas, including tobacco, HIV, racial ethnic disparities, viral hepatitis, vaccines, multiple chronic conditions, health literacy, and other areas. I'd like to focus on one particular plan as an example of our coordination efforts at the Department, and that has to do with tobacco. As you all know, tobacco addiction is one of the most troubling public health challenges of our time. And in fact, in the 21st century, it's forecast that tobacco use globally will cause some 1 billion preventable deaths. And that's a stunning fact that demands our attention and our action. So to address this public health challenge, the Department last year released its first ever comprehensive tobacco control strategy called Ending the Tobacco Epidemic, a Tobacco Control Strategic Plan. This process, in fact, began in the spring of 2010 when the Secretary charged me to convene a coordinating committee across the Department consisting of leaders from every agency to inventory the activities and efforts that were underway and then leverage them together to have maximum impact with our current resources. And we were very pleased to unveil that plan last fall, with activities focused on 4 pillars: engaging the public, supporting state and local efforts, advancing research, and having HHS lead by example. I am very pleased to report to this committee that already we have seen some results accomplished that would not have been possible without this high level of coordination and collaboration. For example, just several weeks ago on July 1st, the Secretary announced that HHS was now completely tobacco-free. And also, in recent weeks, our Centers for Medicare and Medicaid Services, CMS, has released formal guidance on the Affordable Care Act's expansion of smoking cessation benefits for pregnant women enrolled in Medicaid. Also, CMS has formally announced new options for Medicaid beneficiaries, such that administrative reimbursement for quit lines could be put forward. So that's a very important resource to help smokers quit. We're also pleased to report that this action plan has garnered a lot of support from the general community. For example, just last week there was a scientific report released showing a significant decrease in smoking in the movies, which contributes to changing the social norm about this very important public health issue. That report cited the HHS Tobacco Action Plan and is an example of bringing more attention to mass media efforts around tobacco control as well. So we look forward to presenting more progress on plans like tobacco and many others as an example of our commitment to collaboration and coordination. The draft legislation here today, Enhancing Disease Coordination Activities of 2011, recognizes that important role of cross-departmental coordination and collaboration, and we want to thank the committee for your thoughtfulness and insight in putting that effort forward. I should note, however, that Section 222 of the Public Health Services Act already has the Secretary with the authority to create advisory councils and committees and appoint members to those groups. And so with that authority, the Department has established a number of advisory committees which allow the Department to get input from external experts, and then it also allows for the public to engage in the work and policy development process that occurs at the Department. The proposed legislation supports very strongly the efforts of coordination, collaboration in that spirit, but I do want to note that it may introduce some unintended redundancies. For example, the legislation requires that each coordination committee have a strategic plan every 2 years and update that plan every 2 years. And under the current structure, we have our advisory committees establishing their own priorities and updating plans on a flexible schedule. So the bill's requirement for an every 2-year timetable could take away time and resources that could be better used for implementation. Another area I do want to mention is potential costs to the Department that could be associated with this legislation. The Department already commits significant resources to existing advisory committees, and having to spend even more funds on many more committees could potentially take away dollars from other important endeavors and potentially represent duplication of efforts. So in closing, I want to thank the committee for its recognition and promotion of the important role that cross-agency collaboration and coordination play in developing strong policy. I would urge the committee to take into account the current system that exists and I believe works well at HHS for establishing and managing advisory groups. And as always, we at the Department look forward to working closely with you on many, many important areas in public health. Thank you very much, and of course, I'm happy to take any questions on these issues.
Chair, thanks the gentleman. Thanks both of our witnesses for your testimony. I'll now begin the questioning and recognize myself for 5 minutes for that purpose. We'll begin, Dr. Lurie, with you. Congress enacted the Project BioShield Act of 2004 and the Preparedness and All Hazards Preparedness Act of 2006 to build the nation's preparedness infrastructure and foster the development of chemical, biological, radioactive, and nuclear medical countermeasures so the nation could better respond to attacks. Would you please expand on your comments on how these laws have helped prepare our nation?
Certainly. Thanks for that question. As I think we know, the development of medical countermeasures has been a particularly vexing problem because there is by and large not a commercial market for these products. So through these laws, we have A, provided funding to develop these countermeasures, B, provided the assurance that the federal government will be a good partner and will purchase these products if, in fact, private companies come to make them. In doing all of this work and through the enterprise, over time we have continued to strengthen our efforts both to identify what needs to be developed, to identify how it's developed, to strengthen our work with developers and companies, and now to move forward to coordinate the efforts with BARDA in the lead, with FDA, CDC, NIH, and BARDA, so that we now have a much more seamless process for countermeasure development. At the end of the day, however, this stuff takes a long time. It's really expensive, and we have an obligation to the American people to be sure we're prepared. When we started all of this, and when you all decided to help cross this so-called valley of death, we had almost no products in the development pipeline. Now I'm proud to say we have over 70 CBRN products in development and a slew more in the flu area, and we have moved forward to procure a number of countermeasures for the Strategic National Stockpile for smallpox, anthrax, botulism, red nuke threats, et cetera. I could go on and on.
Thank you. Your position, the Assistant Secretary for Preparedness and Response, was created in the Pandemic and All-Hazard Preparedness Act of 2006 to lead the oversight and coordination of the entire medical countermeasure enterprise through HHS. Would you give us your insight on the challenges you've faced in leading this enterprise, what we can do to help you in your position, and in the aftermath of the natural disasters and pandemics of the past few years, can you describe some of the challenges that you and your staff have faced, especially related to coordination, flexibility, and communication?
Great, and I very much appreciate that question as well. You know, I came into this position early on in H1N1, and the importance of coordinating across all of HHS was terribly important, whether it was our public health response or our healthcare response or our countermeasure response. All of those things needed to work together. So through my office and because of the authorities of my office, we've been able in a very regular way to pull together all of the parties end to end on the countermeasure side and through the response side to be sure everybody's working together. You know, as do we all, some of the programs are at CDC, some of the programs are at HRSA, some of the programs are at NIH or FDA, and we all meet together under my leadership to identify gaps and to solve problems. I do sit on the Secretary's Budget Council. I do have the opportunity to review and provide input into the budget process through that mechanism. An area that's worked particularly well has been the FEMC, or the Public Health Emergency Countermeasures Enterprise, which I lead and chair. And again, through the medical countermeasure review, we've really enhanced the coordination of all of the parties so that now everybody sits at the table and sits at the table with product developers at the beginning, identifies the plan, identifies the gaps, and works together going forward. I'd also comment that DOD and DHS participate in this, so our role coordinating there is much broader, in fact, than just at HHS. Similarly, on the healthcare delivery system side, where we have responsibilities, as Mr. Waxman pointed out, for medical surge and for working through issues in the emergency care system. We coordinate and work closely with our colleagues at CDC and HRSA and CMS, the National Disaster Medical System, and hospital preparedness programs, you know, being two major centerpieces of those.
Thank you. My time has expired. Yield to the ranking member of the subcommittee, Mr. Plone, for 5 minutes for questions.
Thank you, Mr. Chairman. Dr. Coe, if I could start with you. You noted in your testimony that under Section 222 of the Public Health Service Act, the Secretary already has the authority to create advisory councils and other committees and to appoint members. As I understand it, the intent of the Enhancing Disease Coordination Activities Act, which is before us today, is not to duplicate that authority, but rather to outline the structure and functions of committees focused on coordinating a specific disease or health condition. The provisions of that bill are modeled on those in the Autism Coordinating Committee, and as we heard in our hearing last week, that's been very successful. So as we consider this new bill, I wanted to be sure that if and when the Secretary elects to establish another disease-related coordinating committee, that it operates in an effective and productive way. So based on the experiences you shared in your testimony, are there certain elements of success that have gone into these efforts that should be reflected in the legislation?
Well, thank you for that question, Congressman, and also thank you for your commitment to public health in general. So as I mentioned, we always review the landscape in terms of evolving public health challenges, magnitude of new issues, and then assess the resources and the responsibilities of various parts of HHS and see how we can coordinate that to the best of our ability. In the examples I cited, many of these had strategic plans, which were very, very valuable because it explicitly put forward the resources we had agency by agency, then also put forward common goals and measures by which we would work together and measure success. So that's an effort that I think has been very, very valuable in many of the areas that I pointed out. And in the Interagency Autism Committee, there's an excellent strategic plan that's also been developed with goals and targets that's being followed. So I think the more explicit the coordination and the goal setting is, that's a major element of success moving forward.
Well, let me ask Dr. Lurie, my colleagues on the subcommittee, most notably Representative Eshoo, have some concerns that the current programs do not adequately address the needs of the pediatric population, would like to see some enhancements that would assist in the nation's ability to care for kids in the event of a public health emergency. Kids make up 25% of the nation's population, so it only seems natural to me that we should prepare for their unique needs in the case of an emergency or disaster. So in that regard, I'd like to ask you some questions. First, is the strategic national stockpile adequately stocked for pediatric populations? If not, how can the Pandemic All Hazards Preparedness Act before us today be strengthened to ensure that the SNS has adequate supplies for pediatric populations? We'll start with that, but I've got 3 questions. So.
Sure, I think those are great questions. And, you know, when I came into this position, I came in facing a pandemic that A, was primarily killing children, and B, I came into it as a mom and looked at this set of issues that relate to strengthening our ability to respond to pediatric issues in all areas. Since this experience, we've done a number of things to strengthen our pediatric footprint. We've hired pediatricians within BARDA, and we've also hired and brought on a chief medical officer to really pay attention to the countermeasure development needs. In addition, we've developed a pediatric and OB interagency work group that advises now each stage of development from countermeasure requirement setting all the way through development and procurement so that we strengthen the pediatric footprint there. And finally, I've directed my staff to look at every new contract we let to be sure that the development of pediatric countermeasures is there from the get-go. So we now have a smallpox antiviral contract that supports pediatric formulation, the new advanced research and development contracts for new broad-spectrum antimicrobials support pediatric populations. We have funded the development of the palatability study so that we can...
Well, let me issue this just because my time is almost out. Is there anything that we don't have in the law that would prevent you from integrating kids into the national preparedness goals? Is there something that we need in the law?
I've tried to think hard about that because I'm always a big fan of getting the authorities we need. My view right now is that we've made enormous progress with the authorities we have, and there doesn't seem to be anything in the way for me of us continuing to make more progress in these areas. At the end of the day, I'll point out that pediatric countermeasures are expensive to develop and test, and the market issues there are like the market issues in the rest of the countermeasure sphere, but more profound. So from an authorization perspective, I feel like I have what I need.
Mr. Chairman, just another time is run out, but just when she was saying she was hiring all these pediatricians, all I kept thinking was that we better pass our bill with the graduate medical, the GMEs. Otherwise, there won't be any physicians to hire.
I was thinking
There we go.
thank you. Chair thanks the gentleman and recognizes the Vice Chairman of the committee, Dr. Burgess, for 5 minutes for questions.
Thank you, Mr. Chairman. And Dr. Lurie, thank you for being here. Thank you for helping our office when you first took your position and the H1N1 was really making its presence felt in the state of Texas. We felt it acutely. Appreciate the efforts from your office to help us discuss that with the Fort Worth Independent School District during the summer. You were concerned about kids. I was concerned about pregnant women, school teachers in particular, who would be exposed to large numbers of children during the beginning of the next school year. And it's one thing to close down the schools in May. It's another thing to close them down in September, where so much instructional time could be lost in the year going forward. And although certainly I know there have been criticisms about how all of that was handled, I think it certainly could have been much more disruptive than it was, and I think that's largely due to your efforts. The issue of pediatric dosages being available was something I became acutely aware of when contacted by the Tarrant County Health Department, that they did not have antivirals available in children's doses and were simply having to make it up as they went along, and that's clearly uncomfortable. I've got some questions for you about the National Strategic Stockpile. I need to set it up a little bit, so bear with me. In July of 2010, I sent a letter to the National Strategic Stockpile, myself and Joe Barton, as the ranking member of the full committee and subcommittee on oversight and investigations, talking about the preparedness through the National Strategic Stockpile. 10 items were in that letter. Number 5 was dealing with the stockpile's ability to deliver threat-appropriate materials in the event of something that required national activation. So we were interested in the methods to secure delivery of threat-appropriate materials from both domestic and foreign manufacturing sites in the stockpile activation. The material provided back to me by Dr. Frieden of the CDC on issue number 5 detailed some of the things that they were doing. As part of that response, Dr. Frieden issued or referenced the Executive Order 12919 with HHS, with approval of DHS and FEMA, may utilize the Defense Production Act authority with respect to health resources. That's pretty broad authority. Essentially, the federal government could take over those things if necessary at the time of a national emergency. But then the question comes up, you don't really have authority over foreign manufacturers, and we do rely on foreign manufacturers for materials, masks, gloves, active pharmaceutical ingredients for some of these materials. So the question then, can you give us a description of how your office coordinates the movement and delivery of special medical countermeasures to ensure the delivery of threat-appropriate materials in the event of a national stockpile activation? That's one. And the second is, in the event of a global pandemic, can you assure the committee that there are the resources available to ensure threat-appropriate materials will be able to be disseminated among the population?
Great. Well, thank you for both the setup and for the question. But first, let me also thank you for your leadership during the pandemic and your leadership both with the pediatric and the OB community. I think largely because of your efforts in highlighting this issue, we now have record numbers of pregnant women vaccinated for influenza. I think it's made a huge difference. It also led us to think very hard about including OB issues in this pediatric interagency working group so that we're sure that we really nail those issues for both the pregnant women and children as we develop countermeasures moving forward.
Mr. Chairman, let me just ask unanimous consent. I'd like to make copies of Ranking Member Barton's and my letter available to the record, as well as the response we got from Dr. Frieden. Let me get this material to you, Dr. Lurie, because this requires some thought and perhaps some research in delivering an answer, but it is important. And really the essential issue is, how do we assure that we're going to be able to deliver threat-appropriate materials to the correct places yes, we can have broad authority in this country, but what do we do if we're getting that stuff from Mexico, the Philippines, China, fill in the blanks? And that's really my main consideration.
It's an important question. It's something that I think we have a number of answers to, and we're continuing to work on, but I think it might use up an awful lot of time. So
all right, we'll get that to you in writing.
If you want to get that to us, we'll be happy to get back to you on
Dr.
it.
Cole, let me just briefly ask you, you referenced quit lines in your testimony. Is that like a 1-800 number?
Right. The number is 1-800-QUIT-NOW, and it's a coordinated national effort.
Have you done any studies to see the efficacy of a quit line as opposed to perhaps a medically supervised program of Chantix, Wellbutrin, or even medical hypnosis in regards to smoking cessation? I appreciate your leading by example. I think that's great that HHS is smoke-free. We need to work on the White House and the U.S.House, but those are those are separate considerations of leading by example. I would appreciate you helping me with that. But I would also appreciate if you could give us some information about what research you've done as to the efficacy of the quit lines as opposed to medical therapy. I was always disturbed in my practice that I was never reimbursed for helping someone with smoking cessation, and yet it might be the single most thing that you could do to help with their future health if you could get them to quit smoking. So thank you, Mr. Chairman, for your indulgence. I'll yield back.
Thank you, Congressman. You raised many good points in your question, and first I should say that we're very pleased at the increasing attention on prevention in general in the country, and with the passage of the Affordable Care Act, there are many preventive benefits that are being afforded to people, especially in the area of tobacco cessation and tobacco counseling. Smoking quit lines have been studied very, very carefully in excellent randomized trials, and those studies showed the benefit have led to the expansion of quit lines across the country, and this 1-800-QUIT-NOW number that's available to anybody in the U.S. And in general, we support using all these measures together: quit line services, counseling, medications when appropriate. We want prevention to be a multidimensional effort so we can move people to a tobacco-free future.
Chair, thanks to gentlemen. Without objection, the letters that you've submitted will be entered into the record. So ordered. And the chair now recognizes the ranking member emeritus, Mr. Dingell, for 5 minutes for questions.
Mr. Chairman, thank you for your courtesy. I will be focusing my questions today on the Pandemic and All Hazards Preparedness Act. My questions are going to be directed to Dr. Lurie, and I would like a yes or no response, if that be possible. We have made progress, but we know from recent events such as the H1N1 pandemic that more must be done to assure our nation's readiness to respond and recognize such events. It's also important to note, as Secretary Napolitano recently did, that one of the evolving threats to our nation is the use of chemical, biological, or radiological devices. Now, first question. In your role as Assistant Secretary for Preparedness and Response, you have responsibility for preparations to address the threat of bioterrorism. Do you believe that a bioterrorism event from a biological weapon remains at or near the top of the nation's most serious threats? Yes or no?
Yes.
Next question. Do you believe that we currently have the necessary medical countermeasures stockpiled to respond to a bioterrorist event? Yes or no?
Not completely.
Okay. Do you believe that the U.S., would you submit to us a statement showing where you feel we need to have more of these kinds of agents stockpiled? Do you believe that the U.S. is now in a position to recognize and respond to threats such as a bioterrorist event or an emerging infectious disease outbreak similar to H1N1? Yes or no?
I think we've made a lot of progress. We have more ground to cover.
But the answer is no.
The answer is no.
Do you believe that the Congress has allocated sufficient funding to develop and procure proper medical countermeasures? Yes or no?
I think we've made a lot of progress. We have more to
The
go.
answer is still no.
The answer is still no.
One of the greatest problems we faced during the H1N1 pandemic was delays and interruptions in the production of vaccine, which has been an ongoing and continuing problem for many reasons. Your testimony mentions the Centers for Innovation in Advanced Development and Manufacturing as one way to increase domestic manufacturing and surge capacity for medical countermeasures. ASPR put out a request for proposals in March. How many centers will ASPR support?
Well, I should tell you that the deadline for submission is today. We've already been receiving submissions.
Would you give us then, for the record, an answer to that question?
Sure.
Now, you state in your testimony that these centers will also be available to manufacture vaccines in the event of a pandemic. Given this, will you take into consideration geographic questions when choosing where to establish these centers? Yes or no? In other words, you're going to consider geographic questions as where you're going to locate the centers.
I think the most important factor to consider is whether the proposers can do the job.
Of course. Now, do you believe that the centers will help reduce U.S. reliance on vaccine manufacturers based overseas? Yes or no?
Yes.
Would you submit for the record a little monograph as to why you feel that would be so? Do you believe that these centers will have a role in supporting small companies who have developed or are currently developing medical countermeasures? Yes or no?
Yes.
And in the case of places like the University of Michigan, where they have, or other universities where they have substantial spin-offs, this would be a very big help. Do you agree?
Yes.
Now, Doctor, as you know, the Department of Defense has put out a request for proposals, advanced development and manufacturing of medical countermeasures. Have you been working closely with DoD to minimize any potential duplication between these centers? Yes or no?
Yes, we've been working very closely from the very beginning, they with our proposal and us with them.
Would you submit to us, please, a brief statement as to what you are doing and how you expect this to assist you and DoD in avoiding duplications and other kinds of unfortunate events? Please. Mr. Chairman, I thank you for your courtesy. I yield back the balance of my time.
Chair, thanks the gentleman. Recognize the gentleman from Illinois, Representative Shimkus, for 5 minutes.
Thank you, Mr. Chairman. Thank you for attending. I'm going to kind of stay on my focus on Dr. Lurie also. My first question deals with your proposal to extend the shelf life on MCMs. Why is that important, and can you go in a little bit more detail?
Sure. Well, right now, as
and I think for others who aren't physicians, shelf life, there's a issue there, and we don't know really much about the details.
Well, first, let me say that in all of this, our primary concern is continuing to make available safe and effective medical products and countermeasures for the American people in an emergency. Particularly with some of the newer countermeasures that have developed, and as well as antibiotics and other things that have been around for a long time. If they are stored properly and according to standards, they remain safe and effective. It turns out that many of them remain safe and effective and maintain their potency beyond the initial data which everyone thought that they could guarantee their safety and effectiveness. As long as they still work, as long as they are still
And we know that by pulling them off randomly and checking.
We know them by pulling them off randomly. We know them by testing, and there is a very extensive testing process that goes on.
And the stored agents are basically the ones that we most assume will need readily available.
So they might be vaccines, they might be antimicrobials, they might be antitoxins. And we test all of these regularly as part of our stockpile maintenance. Yeah,
let me go to. I think a lot of concerns is what you have on hand and what may be used that's not on hand, and the ramp up of something not expected. And in your testimony, you talked about the idea of a strategic investor. Mm-hmm. How does that differ from, well, what is that by definition? Because it's a little vague. And is that similar to a private venture capital firm, or are you proposing that the government take the role of a venture capitalist in this, and that's what this strategic investor is?
So the strategic investor is a non-government, private, not-for-profit entity that does some of the things that venture capital companies do, but focuses strategically to meet the federal government's needs in areas that it's not met now. You know, these Centers for Advanced Development help us with the technical problems companies face. It's also the case, as we've looked at our experience, that a lot of companies fail for business reasons or because they can't leverage other resources that accelerate really great ideas. You know, the intelligence community uses this kind of a mechanism to get things that it needs. NASA uses this to get what it needs. And we've researched, I think, this very carefully and think as one of the components of the medical countermeasure review, making sure that companies succeed or helping companies succeed for business reasons is terribly important. Now, this is envisioned as a private, not-for-profit entity, not run by the federal government. It's not like the federal government's going to get into the VC business.
And that's why we ask these questions, because I think if I was going down, I was trying to figure out who is this, who manages this, how is this controlled, and I think you answered that question. Okay. And I appreciate it. The last question I have is on the Medical Reserve Corps. How effective has that been in current disasters, and how does the emergency system for advanced registration of volunteer health professionals, is that segued into that? Is it fully complementary, and are we seeing some results, positive results from that?
You know, so the Medical Reserve Corps is a volunteer cadre of people who sign up in their communities to volunteer in case of emergencies. And they have training, and they meet regularly, and they're rostered, and they're available when something happens. They're not a federal asset. They're a state and local asset. And so
the question is, have we seen them called out? I mean, it's 5 years old. I mean, in essence.
They respond a lot to local events, right, and in fact make it often so states and locals can handle things on their own and don't need the federal government. So yes.
And then how does that, the emergency system for advanced registration and volunteer health professionals segue into that?
So you know that whenever either a state or the federal government calls people up, we want to be sure that they're credentialed, they're who they say they are, they've got the skills and the credentials for who they say they are. In an emergency, it's not the time to figure that out. You really want to figure that out beforehand. You know, I'll just point to our experience during Haiti, where we had thousands of people who wanted to help. They were all well-intentioned. Many of them were extremely well-qualified, but we couldn't process and certify all of those people in the middle of a disaster. You have to do that in advance so that you are ready to go when you have a disaster.
And my time is hard, but the question is it working? Are we doing it? Versus, I know what the real world we want it to be, but is it working?
So some states have very, very strong advanced registration and credentialing programs, and those are working quite well. We are continuing to provide technical assistance and supports to other states to get up to speed.
Chair, thanks the gentleman. And recognize the gentlelady from California, Ms. Capps, for 5 minutes for questions.
Thank you, Mr. Chairman Pitts and Ranking Member Pallone, for holding this very important hearing. All too often, disaster preparedness is addressed in hindsight, once a disaster has already taken place, rather than before when it could have been more effective. I'm proud of the work that this committee has done to ensure that we are better prepared today, and look forward to reauthorizing PAPA to ensure that we are even more ready if and when disaster strikes. Today we are here working together to ensure that important safeguards are in place, and that as a result of this work, communities will be able to better respond to and recover from public health emergencies. Dr. Lurie, as you might be aware, My district is home to one of 2 nuclear power plants that the Nuclear Regulatory Commission recently confirmed are located in the highest seismic risk areas in the country. In Japan, an earthquake and tsunami breached all the safeguards at Fukushima power plant and put numerous communities at risk. Needless to say, my constituents are very concerned about a similar potential threat in their backyards. And even the NRC has a recent report pointing out numerous safety deficiencies in nuclear plant oversight. So my concern is, and question for you is, what is the current status of our country's preparedness from your vantage point to adequately address radiation exposure? Are there some particular steps we should be taking that we are not? And just your general response.
You know, it's a great question, and I think you know that as a federal government, we did a nuclear power plant accident exercise a couple of months before the Japan event, confirming that nothing is really unthinkable. Since both of those events, we've gone back and we're in the middle of a systematic review of all of our public health gaps in radiologic preparedness. So that is right now underway. That is including an assessment of whether we need to be stockpiling potassium iodide for children and going back and reviewing all of the science related to that. At the same time, we are very aggressively developing a set of countermeasures for radiologic emergencies, not only for the blood and bone marrow suppression, but for lung, for the intestinal system, and for skin. So
I, for one, would like to, I'm going to be very interested in what you come up with, and I would like to ask if it would be okay with the chairman if we ask for that report to be made available to this committee as soon as it is completed.
We would be delighted to come up and brief you about what we learn as
that would even be better.
Yeah.
Just in one general area, potassium iodide tablets have been available to my community members in the surrounding region, but since we saw the markers of miles considered exposed in Japan to have increased dramatically, that's one question that I think would certainly is certainly on the minds of my constituents, as they will also look forward to the results of your study and hope that it will be completed at the earliest possible time.
Right.
And there's another related, but not necessarily just confined to nuclear exposure, but surge capacity is another topic that is very much on my mind, background in healthcare, and that, of course, is the ability to respond in case of a mass casualty event, whether that be a tornado, a bombing, an outbreak of an infectious disease. The ability of any community to respond to a massive influx of casualties capacity depends on care across the system, including ambulatory care, hospital care, critical care, trauma, and emergency care. So, some mass casualty events take weeks or months to develop, such as a pandemic flu or a biologic attack, but many events provide no such warning, as you know. After a terrorist bomb explosion or a natural disaster such as an earthquake, hospitals will and the community would have to be able to respond without any assistance in the immediate minutes and hours without any assistance from state or federal authorities. Such assistance cannot arrive in time, and that's why I believe a surge capacity is so critical to response capabilities. So, and there's not enough time to go into this in depth, but could you talk a little bit about the hospital preparedness program and anything else you want to bring up?
Sure. No, thank you. So the hospital preparedness program has been central to getting hospitals prepared to surge in case of emergencies. We also recognize two things that are really important. It's not about only the individual hospital. It's about all the entities in the community being able to do this. And at the end of the day, if we're going to be able to have the surge capacity we need, it has to be built on the back of strong day-to-day systems, especially for those no-notice events you talk about. So dealing with issues like emergency department boarding and crowding, which I know this committee's had hearings on in the past, central issue here, getting people to the next lowest level of safe and appropriate care in an emergency, something else that's really central. So as we are moving with the next generation of the HPP program, that set of issues about surge capacity is front and center, being sure that we have the ability to work within the HPP program to innovate and be flexible and test some new models, and that is also really critical.
Thank you. And Mr. Chairman, if I could just beg for one follow-up, that anything you could do to help our communities, just as you had an evaluation or training of nuclear or capacity facilities, I think our communities would like to train and go through some preparations to be prepared.
That's a great comment, and the program, we do continue to support training and exercising all the time. I would make one last comment, is I've looked at the no-notice disasters that have struck this country since I've been in this job. There are many times when states and communities have not needed to call the National Disaster Medical System to provide medical care. They've surged and handled it on their own, and I continue to hear it was the hospital preparedness program that got us ready. It was that training and exercising that I really didn't want to do, but we did anyway, and it really helped. Most recently in Joplin, we saw them be able to stand up a temporary hospital extremely rapidly after disaster. And that was done with a lot of support as a result of the kinds of things that HPP does. Similarly with a lot of the flooding events and others that have happened. So in all the major events that I've been here to see, I hear from emergency doctors, hospital administrators, state and local public health about this very issue. We did it because.
Excellent. Thank you very much. Thank you, Mr.
Chair. Thanks, gentlelady. Recognize the gentleman from Michigan, Mr. Rogers, for 5 minutes for questions.
Thank you, Dr. Lurie, and thanks for working with us on this piece of legislation. Hopefully we can continue to work together to perfect it in a way that we can here in Congress, if there is such a thing.
Great collaboration.
Yeah, thank you. And I just want to follow up on Mrs. Capp's line of questioning. It was just a point of issue that I hope you can help us with is during an emergency, from a terrorist attack or as we saw with H1N1, it's critical that there is a point person, somebody that makes the decision, somebody that is absolutely in charge. It's not CDC, it's not NIH, it's not the FDA or anyone else. It's you.
That's right.
How can we improve the functions at HHS to ensure that you are, in fact, in charge of the preparedness efforts? And we understand HHS does work on the consensus model brought by peer review and other things. But in this particular case, I think it's incredibly important that there is a person in charge, or it takes longer, as you know. How can we help you clarify that?
Thank you, and I very much appreciate the question. The original intent of the legislation was to do just that. And I have found through this experience that indeed I have the authorities that I need to be in charge. We have strengthened our policy coordination and our preparedness planning with all of the entities involved. So, how you're going to, being in charge during a response also requires sort of being in charge and providing that policy direction in all the preparations so that when the balloon goes up, you're really ready.
And do you find you have that?
And I find that the collaboration with the sister agencies in HHS, I don't think it's ever been better. We are working extremely closely together. I think they recognize and respect the fact that we provide policy direction and are in charge. And I think all of the efforts that we've undertaken to coordinate across HHS have done that. Now, during response, it's really the Secretary's Operations Center, run by the Office of Preparedness and Emergency Operations in my office, that is the belly button for those activities, the central coordinating point for our operational response, and it's my office as well that is the central coordinating point for the strategic and policy response. And that has become increasingly recognized with each of the events that we have dealt with this year. And I very much understand that I am in charge and that I am accountable, and I think I have the authorities that I need to do that.
I'm not so interested if you know you were in charge, because I think you do. It's the other folks at the table I want to understand that you're in charge.
I appreciate that.
Yeah, thank you. I'm going to move to the FDA here for a minute. Last year, the HHS conducted a comprehensive medical countermeasure review. In that review, you identified the need to improve regulatory science at the FDA to ensure medical countermeasures are given a priority. Specifically, You said the FDA needs, and I'm going to quote here, to work with sponsors to identify and help resolve scientific issues as early and efficiently as possible, end quote. I couldn't agree more with that statement, and I think that's absolutely critical. Countermeasures are different than the next generation of, they're different from Viagra, they're different from whatever, clearly. And so having the FDA involved early, to me, is incredibly important. Can you explain why improving regulatory science at the FDA is so important, in your view?
Sure.
And why early intervention may be different and as important in countermeasures as it is different from other drugs?
Let me do the early intervention part first, if I can, because I think it will help explain better the regulatory science piece. You know, if a company is developing a product and gets either hung up scientifically or has a pathway to regulation that's not as clear as it could be, it's really hard for that company to go forward. We have, as I think you know or have heard, really transformed the way in which we work with companies so that now at the beginning, at the get-go, we do what I affectionately as a primary care doctor call case management. We sit down with scientists from FDA, NIH, CDC, BARDA. We look at what the plan is. We provide scientific input and expertise, and then now on a very regular basis, we sit down, review the process and the progress with those companies, and try to troubleshoot. And FDA is now at the table and a very active participant. It's been very welcomed by companies, and I get feedback about that all the time. Now, if in fact you are moving along on a plan to develop a product and to get it approved or authorized by the FDA, and, for example, you don't have the tests necessary to know how effective it's going to be, the time to develop those tests isn't when the company is ready to submit a dossier to the FDA. The time is very early on in the development process. A great example of that has been, you know, the sterility testing for flu vaccine, which hadn't changed for 30 or 40 years. Now, you know, we are doing things early on to works with FDA and companies to change that process. So what you need are the tools. You need the scientific tools to evaluate whether a product is going to be safe and effective. And the science has changed so rapidly that we need to be able, and we have to ask FDA to use new science, not antiquated science, to do its job. That means that it has to be at least at the pace of or a step or two ahead of where all of these companies are, so that when the companies are ready to have their products evaluated, the science is there to do that. Animal models are another great example. We're working hand in glove with NIH and FDA on developing those kinds of animal models so that at the end of the day, if an animal model is an appropriate way to move forward, we can do it. So regulatory science becomes central to being able to get a product approved and to clarifying and I think speeding up a regulatory pathway.
And early intervention with those folks is
much earlier
critical.
intervention. Yeah. And we have been doing that, as I said, since the Secretary's countermeasure review. It seems to be working quite well. In that early intervention, we sort of make a plan. And the vaccine front, we've moved forward with also working on some timelines so that we and the BARDA, the sponsor, FDA, agree on the plan, agree on timelines, and we manage to those.
Great. Thank you.
Chair, thanks, gentlemen, and recognize the gentleman from Louisiana, Dr. Cassidy, for 5 minutes for questions.
I thought I was third in line. So, Dr. Koh, I appreciate the anti-tobacco efforts, but let me just be a contrarian for a second. We've just raised taxes tremendously on tobacco. Do we know that the effects of this task force, which I'm sure consume a fair amount of resources, are they responsible for our decrease in tobacco usage, or would it just be the fact that we're taxing the heck out of it and that's making it less affordable for people to smoke?
Well, there are many parts to tobacco control, Congressman, and the plan that we have put together really encompasses a multi-pronged approach. So you mentioned one, which is raising the price, and just about every state has done that in the last 10-plus years.
So let me ask you, has there been any sort of, for example, regression analysis to see if there is a secular trend that's just continuing downward usage as we increase taxes versus this kind of significant commitment of federal resources, which, frankly, I like, but I'm wondering, could we redirect those resources if taxes are doing it all for us?
Congressman, this is one area in public health that we have tremendous science. We have tremendous data. We know what works. We know raising the price works. We know that community-based interventions work. We know that quit lines work. We know that providing cessation services to smokers who want to quit is extremely helpful. So the challenge is to put it all together, and so that we can have a country where we are reducing the suffering here. We do know that tobacco usage, which was declining for many years, has stalled over the last 7 or 8 years, and that's actually why the Secretary asked me to convene this group. And so we hope we can.
Now let me ask you, because again, I think as part of the CHIP reauthorization last year, there was $1 a pack placed. Now, was there any sort of downtick in tobacco usage with that $1 a tax, $1 a pack tax? And did that precede the efforts of your interagency group?
It preceded the efforts of our group, and the economics of raising tobacco prices has been extremely well studied. In fact, we know that raising the price about 10% decreases consumption, 4% for adults, and even higher for children. So that was a federal effort from several years ago. I think you're referring also to state efforts, and each governor of both parties actually in just about every state has raised taxes over the last decade or so. But I do want to stress again, Congressman, that's an important and well-studied intervention, but it's only one intervention. And I guess,
but what I'm wondering, does that overwhelm the efficacy of all the others?
Oh, we need all the efforts. I remember you're a physician. I
accept that, but I'm just wondering, again, as we have scarce resources, I guess I'm asking, is there a secular trend whereby all others pale in significance? Sure that if taxes are not raised, then we need the others, but if taxes are raised, the others are obviated.
You know, we need the price increase can help to some degree, and I've recited the numbers to you, but we also need that. Tobacco addiction is a really tough addiction. I know you know that as a health professional, Congressman, and so do I. I'm a physician who's cared for patients for over 30 years. So when you see people who are hooked and they want to quit and they haven't been able to, you need every resource, and you also need additional resources to prevent the next generation from taking up the...
I'm just asking, is there statistical data to show that these other interventions help over and above? But
absolutely.
I'm almost out of time, so let me just try.
Yeah, let me just say, Congressman, this area has been extremely well studied. I'd be glad to provide you more materials, but we need many approaches here to tackle this.
That would be good. If you could. Again, I'm not saying we shouldn't do it. I'm just saying if we've got limited resources, where do we spend it, sort of thing. Okay. Let me ask you also, just broadly, as long as I have you, and either of you can answer, but I'm struck that sometimes it seems, as you know, perhaps you know, I'm a doctor that treats diseases of the liver, right. And its societal and economic impact is tremendous. And yet the amount of funding from the federal government kind of pales in significance to some other illnesses which arguably don't cost more, if you will. Is there any sort of metric as we do funding for federal activities that I can imagine a metric being morbidity, mortality, years of life loss, potential, because smallpox clearly doesn't kill anybody now, but the potential death is tremendous. Is there any sort of metric applied to this, or is it more or less historical funding moving forward?
I can start, and Congressman, I really appreciate your support of the viral hepatitis strategic plan. I remember when you testified and presented in front of our congressional briefing, and I know you've spent much of your career caring for patients with hepatitis, so we really appreciate that. And you well know that if you intervene on hepatitis, you can prevent liver cancer and prevent liver transplant, all of which drives up healthcare costs in this country. So with respect to your question, obviously these are very challenging budget times. We've launched this plan to address a rising public health need. We do need to bring in as many resources on the table from
but let me ask, because I'm frankly out of time, but I'm asking, do we have any sort of metric by which federal funding for the addressing illnesses is applied, or is it historical funding that kind of continues forward? Is it active politicians determining how we spend our dollars, or is there a metric that is applied that scientifically says we should put X number of dollars here, Y there, and Z here?
Well, those metrics have been well defined for tobacco. For hepatitis, less so.
I'm just saying globally. Okay, we have this death rate from HIV, this from breast cancer, this from prostate, this from hepatitis, this from smallpox.
Right.
And do we have a metric that then determines how we do our spending?
Again,
they're not, because...
Yep.
Yeah, okay.
Again, there are state-by-state guidelines for spending on tobacco that are very well defined from scientific data. On hepatitis, tobacco, there's less so.
Okay, I yield back. I think I know what the answer is.
Chair, thanks, gentlemen, and recognize the gentleman from Georgia, Dr. Gingrey, for 5 minutes for questions.
Mr. Chairman, thank you so very much. And I was going to direct my questions to Dr. Nicole, but as usual, my good friend and colleague from Louisiana stole all my thunder, and I'll have to then direct my question. I'll let you take a breath, Dr. Coe, and I'll direct mine to Dr. Lurie. Dr. Lurie, you mentioned in your testimony about the Emergency Medical Countermeasures Enterprise Review, MCM review, in August of last year that articulated, and I quote, a vision for a nimble, flexible infrastructure to produce MCMs rapidly in the face of an attack or threat, including a novel, previously unrecognized natural occurring emergency and governments might use a drug-resistant form of bacteria or other infectious disease as a weapon against us, against the United States.
Well, one of the great things is that the scientific methods and tools to do all kinds of things, what we call synthetic biology, has progressed tremendously. One of the very scary things is it's become a lot more automated and a lot easier. I don't know if you've seen these articles about the DIY, the do-it-yourself, garage manufacturing of.
We actually heard a little bit about that activity from our first witness, our colleague, Charlie Dent, in regard to some of these synthetic drugs.
And so, the technology to genetically engineer all kinds of deadly organisms is there, it's available, it's becoming more available, and we have to be very prepared for those kinds of things.
So a real threat.
Yeah, it's a real threat.
Well, look, let me ask you this: if we are to meet these emerging threats, we need more novel antibiotics. Yet our current development is not as robust as it needs to be. And you mentioned in your testimony that the MCM review had identified choke points where product development was, and I think I'll quote you, stalling or failing, unquote. Can you take a moment and describe some of these choke points and disincentives in the current antibiotic development pipeline? Because I have some real interest in this area.
Right. No, I appreciate that, and I'm glad you have interest in this area because antimicrobial resistance is terribly, terribly important. In the medical countermeasure arena, we focus on antimicrobial resistance for two reasons. One is because of the genetically engineered set of issues. The other, quite honestly, is because antimicrobial resistance complicates our ability to treat and save lives from trauma, from H1N1, where something like 40% of kids died from methicillin-resistant staph, complicating their H1N infection, et cetera. So if we're going to meet our mission in the countermeasure arena and in the preparedness arena, we have to have novel antibiotics. Okay. Now to the sets of issues about the choke points.
Might be a little off the subject matter of the day, but I mean it would be true too in cancer chemotherapy patients, whose immune system is beaten down. They have no platelets. They have no T cell lymphocytes, and all of a sudden their own enteric bacteria is a tremendous threat to them. So, and they need more than just the usual off-the-shelf third-generation wonder drugs.
Good point. So one of the things that I think is not as appreciated about this whole medical countermeasure enterprise that we're embarked on is that an awful lot of the developments that are coming through this pipeline, whether it's novel antimicrobials or a next-generation ventilator, actually have benefits to a broader population in this country, even if we are never attacked, for example, or don't have a new kind of threat. And a goal is for us to do those multi-use and dual-use things as much as we can.
Absolutely.
Our primary mission is to meet our counterterrorism and biological.
I've got 30 seconds left, so I'm going to shift just for a second. Mr. Shimkus was asking you a little bit about our preparedness for a disaster of any kind, and I'm thinking Katrina, because I remember jumping on a plane. I've been out of the practice of medicine for a couple of 3 years and flying down to Louisiana and just say, here I am, I've got my white coat, my stethoscope, and here's my medical license. It's still active. Let me help out. I don't think the Red Cross had any way, shape, or form of checking on me, whether to see if anything had been suspended or whether I truly was an OBGYN or maybe somebody with a criminal background, indeed. But in any regard, I think what he was trying to get at was at the federal level. You said the states, and I think the states are indeed doing a good job in regard to that. Some, not, so hopefully all of them will. But we need to get that data, don't you think, at the federal level, where somebody on the ground, when the next Ms. Capps talked about, if another disaster, obviously we all know another disaster is going to occur of some shape or form, be it an earthquake or whatever. But we need that information, and if you could just comment very quickly, Mr. Chairman, if you'll let her do that, and then I'll yield back.
First, I just want to comment that when Katrina hit and people came here, I walked into the armory with a stethoscope around my neck. They said, "Are you a doctor?" I said, "Yes," and they sent me loose. I didn't even show a license. So I do think that we have to protect people and let them know, be sure that they are who they say they are, and they're really qualified to practice whatever their profession is. I do think we need a national system to be able to rapidly look at somebody's credentials and give them the okay. We also have a set of challenges that we continue to face because state by state, there's not license reciprocity across all states. So a governor can, use I think we talked about it in another meeting, their magic smoke stick, and say, in an emergency, situation, I'll accept licensed providers from another state and do that. But everybody needs then that mechanism to know, are they licensed providers, and to have that work in a hurry. On the federal level, we credential everybody in advance through the National Disaster Medical System, and we have been working very aggressively since the Haiti earthquake to be able to credential people in other specialties, particularly in the critical care area and some of the specialty surgical areas and trauma areas where we don't necessarily have a full cadre of people on each team, so that when a disaster happens, we can pull those volunteers from anywhere in the country and put them to work joining our NDMS teams, and that's actively underway.
Chair thanks the gentleman and recognizes the gentlelady from North Carolina, Ms. Mark, for 5 minutes for questions.
Thank you. I appreciate it, and thank you both for being here. I'm sorry I had to leave for a few minutes. I understand that there are like 44 million doses of the first-generation anthrax vaccine for the strategic national stockpile for civilian use. Is that roughly about right?
I would have to check on exactly what the number of doses in the stockpile is now, but we are continuing to add to it.
Well, I know that's a lot of the budget, obviously.
Right.
And I know back in 2004, HHS issued a requirement to purchase 75 million doses of a second-generation anthrax vaccine. How are you going to move forward on that? Do you know? I mean, is that something you've looked into?
Well, so issuing the requirement, really means that we have a public health and preparedness need for that. Sometimes when we issue a requirement, there's something kind of off the shelf already licensed that we can go buy. Sometimes when we issue a requirement, that product doesn't exist and we have to make it. That's what the advanced development piece is really about. And so we have invested in the advanced development of a next generation anthrax vaccine, largely because the current vaccine really takes multiple doses to develop immunity, and isn't ideal from the perspective of needing to respond to a public health emergency involving millions of people.
But a second generation that is being developed, is that
We are seeking next generation vaccines that would, when they are developed, and the requirement is that they have to meet certain, specifications, so that ideally we'd like something, that's one shot and works quickly. We're not there yet, and the development process is a great example where science is hard. The development process is cumbersome, and it takes really all the best scientific minds and the creativity of many of our industry partners to do that.
Well, is this another area where you have to have investors that are willing to do this, or how does it? I mean, I know all this, if you produce these countermeasures, it's very expensive. What kind of tools do you have at your disposal?
It's a great question. So right now we use advanced research and development funds to be able to do that, and as you probably recall, Papa gave us the authority to spend money on these advanced research and develop purposes, and that's what we need to do. The strategic investor seeks to do two other things that are really important to think about. One is that, some of these companies have great scientific ideas, but not a lot of business expertise. And so fail not for scientific reasons, but for business reasons. And so the strategic investor, first of all, seeks to help them with those business issues. And secondly, it seeks to identify companies that might be working on something for a commercial application. They don't want to work on anthrax because there's not a good market for it. But they could say, you've got a really great idea and something innovative, and we're going to take us in our venture capital-like state, we're going to sort of take a risk, invest in you, and working with us, say, we want you to take this platform, this idea, and apply it to the anthrax problem. That's exactly what it's intended to do.
Yeah, if you've already answered some of this while I was gone, I apologize. So I can always look at your testimony. But the strategic investor is actually working with HHS or for HHS. Is that what I understand?
The strategic investor, as I explained to Mr. Rogers, and I'm happy to again, would be a nonprofit, private nonprofit entity that exists outside of government.
Okay.
But what we have to do is say, here are the products that we need you to invest, the kinds of things we need you to invest in. We have a requirement for a next generation vaccine, whether it's for anthrax or purple spots, and please, go stimulate the development of those things through the ways in which you work as a strategic investor.
Well, then, maybe he asked the same question, but about the strategic investor, is that someone that is actually like a consultant to HHS or something? Is that
no? It's not. It's
a volunteer.
No, I think it would be a private, not-for-profit company, ideally, and it would act in many ways like venture capital companies act, but also act to invest strategically. So one of the things I explained is that the intelligence community does that now. NASA has done that in the past. There are a number of examples across government where that's been very successful.
And then
because we didn't dream it up ourselves.
Is that the type of thing that you would be looking at?
Yes,
on this,
we're looking for the authority to start a strategic investor so that we can use this additional tool to get the kinds of products we need.
Thank you very much. Thank you, Mr. Chairman.
The gentlelady yields back. The gentlelady from Washington State is recognized for 5 minutes for purposes of questions.
Thank you, Mr. Chairman. My questions relate to the Enhancing Disease Coordination Activities Act of 2011, and I wanted to ask how the committees for specific diseases and conditions will be established, and then how the bill changes the current process.
Well, first of all, Congresswoman, thank you for your interest and support of public health. I know you've been a leader in many areas, and we appreciate that. In my testimony, I did review a number of areas where we have strategic plans and implementation efforts, and then also did review that we have actually many advisory committees up and running. So the proposed legislation supports that general theme, which we applaud. And in fact, the mission of my office, the Assistant Secretary for Health's office, is to advance that coordination on behalf of the department and the country. The provisions in the proposed legislation that require a strategic plan update every 2 years might hold us to a level where we are perhaps spending too much time on that effort and not enough on implementation. So the current status that we have offers us more flexibility. And then I did review and mention that the unintended consequence of a legislation like this might be to drive up costs, because putting together committees and running them adds to our budget issues. So those are some of the areas that we reviewed for you. Okay.
In our experience in developing a strategic plan for Down syndrome, the patient advocacy organizations and private research foundations provide critical insight into what is needed to move a research agenda forward. And for example, as we speak, the Down syndrome community is in the process of working with the National Institute of Child Health and Human Development to establish a consortium that includes patient advocacy organizations and researchers. This interaction is critical to furthering one agenda, and I have a little bit of a concern that the draft bill we're discussing today keeps too much authority with the federal agencies with respect to the development of a research strategy, possibly to the detriment of the collective goal of finding a cure or treatment. And I just wanted to ask you to comment, and could the legislation be strengthened by including a role for stakeholders?
Well, thank you for raising attention to that particular issue, and we are pleased to report the evolution of that consortium, as you just mentioned, and there is a very concerted effort at NIH to have a cross-trans NIH coordinating committee on Down syndrome, which I understand is up and running and moving very, very well. In all these efforts, current and proposed, we make special efforts to bring in the best experts in the country so that we can do our work really informed by people who are learned and who have spent their careers studying these issues. And then we want the portfolio and the public health areas addressed to focus not just on research, but on services and public health dimensions in the broadest sense. So that's what we try to do currently. I think the proposed legislation really resonates with that theme as well.
Okay. Thank you. I appreciate you answering those questions.
Thank you.
Oh, I'm sorry, I didn't see you. You came in so quietly. The chair now recognizes Mr. Green from Texas for the purposes of questions.
Thank you, Mr. Chairman, and I know it's unusual for a Texan to sit quietly, but I want to thank each of you for being here. This is my first term in Congress, at least on the Energy and Commerce Committee. I haven't been on the Health Subcommittee, and I appreciate the opportunity to wave on the hearing on H.R. 2405, introduced by both Congressman Rogers and a number of members and myself. I'm original co-sponsor of the legislation. I'm pleased it's a bipartisan piece of legislation. It appears there are a few issues remaining to be worked out before this bill moves to subcommittee markup. And I know there's an interest in ensuring special consideration is given to children during national emergencies, and I hope we'll resolve this issue before the markup. The University of Texas Medical Branch's Galveston National Lab is one of the two national biocontainment labs constructed under grants awarded by the National Institute of Allergy and Infectious Disease and National Institute of Health. And I'm proud much of this research is literally performed in the backyard. I have a district in Houston, and I was happy during Hurricane Ike that there was lots of damage, but the lab was very safe. At this BSL Lab 4 lab, research is conducted to develop therapies and vaccines and tests for diseases like anthrax, avian flu, bubonic plague, hemorrhagic fever such as Ebola, typhus, West Nile virus, influenza, and drug-resistant tuberculosis. I have a personal interest in this legislation because my daughter was actually at UTMB during her fellowship and did some work there and studies at the BSL lab. And believe me, when you talked about my concern from our colleague from Georgia, Dr. Gingrey, about I was at the Astrodome when we have evacuated 250,000 people from New Orleans, and you're right, Doctor. There were folks running around everywhere because the medical community in Houston literally came together, and I was amazed at what happened. And as we know, medical facilities, nonprofits, and profits sometimes compete with each other and their neighbors, but I watched them that day doing such a great job on triaging these folks who literally were picked up in New Orleans and had no medication, no medical records, unless they were veterans. In those cases, we were very lucky. But my concern today is that Texas A&M, University of Texas, and Baylor College of Medicine, along with Texas Children's Hospital in Houston, along with GlaxoSmithKline, along with many other distinguished, are partners in a newly established and developed National Center for Innovation and Advanced Development and Manufacturing in Texas. The purpose of the center will be to develop medical countermeasures to ensure domestic vaccine manufacturing serve capacity for emerging infectious diseases, pandemic, influenza, and other threats during public health emergencies utilizing flexible and multi-product technologies. These public and private partnerships, along with academic research institutions, are vitally important to both the federal government and the private companies as we work to develop novel bioterrorism measures. Solicitations for these efforts were issued by HHS on March 30th of 2011. My first question is, can you discuss the Center for Innovation and Advanced Development Manufacturing and the process going forward for these important institutions, Dr. Lurie? And I believe these centers will be at the forefront of developing medical countermeasures needed by our country in the event of a bioterrorism event.
Thanks so much for your question and for your recognition of the advanced development and manufacturing facilities. You know, they were another critical piece of the recommendations of the Secretary's medical countermeasure review, and they are intended to provide technical expertise and core services to the small companies who get into the countermeasure space and need help. You're right, we did issue the request for proposals, and the deadline for proposals is today. We are receiving applications, and we're very excited about that. And we will be reviewing those applications over the course of the year, working to be sure that we can identify the very best entities to do that job. And then after that, hope to make one or more awards.
One of the concerns I have is BARDA has issued contracts that are fulfilled by international companies with production facilities in Europe. This leaves open the question of supply security and job creation in our own country. Is BARDA committed to allowing contract modifications for pandemic flu vaccine development that will bring some of those jobs back to the U.S. so we can supply, so you can supply us with these for these contract modifications?
We are very focused on domestic manufacturing of our critical countermeasures, including pandemic vaccines. And that's been the focus of much of our work.
Okay.
And I think that certainly what happened in the pandemic very much showed us the criticality of domestic manufacturing.
Okay. Thank you. Mr. Chairman, thank you.
Chair, thanks, gentlemen. That concludes our first round of questioning. We'll go to one follow-up on each side. Dr. Burgess, recognized for follow-up.
Thank you, Mr. Chairman. Dr. Lurie, Representative Markey of this committee amended the Public Health Security and Bioterrorism Preparedness and Response Act in 2002 to make potassium iodide available to state and local governments to meet the needs of all persons living within a 20-mile radius of a nuclear power plant. However, the Nuclear Regulatory Commission in both the previous administration and in this administration has not enforced this provision. Have there been any studies done on the health effects of the different health effects done at different distances? And will we have a large enough supply of potassium iodide to provide for us in a 20-mile radius?
Thank you for that question, and I think it's a question that's been on everybody's minds since Fukushima, and certainly planning for a radiologic disaster is part of our all hazards preparedness. You know, that disaster has caused us to go back and try to look at what all of our public health gaps are, and to try to look at what, you know, should there be a requirement for potassium iodide, particularly for children, in the stockpile, and then how much should we stockpile? How much should that be? So, because we in public health like to apply the best available science that we can, you know, going back, we've been reviewing all of that. We're doing a lot of modeling right now to determine is there a requirement and how big it should be so that we can protect children. It's fair to say that I think that Fukushima sort of challenged a number of our assumptions.
Sure. Well, let me ask you
about
this.
An event.
I mean, apparently it's my understanding that you have the authority to purchase the potassium iodide. Is that correct?
We have the authority.
And you have the money. The money has been appropriated in previous Congresses. Is that correct?
That's right.
But the money's not been spent.
So right now we are in the process of figuring out. So we had pediatric potassium iodide in the stockpile, you know, and that is now set to expire over the next year or two. And so what we need to figure out right now is how much do we need to have in the stockpile to adequately protect the American people. And that's what we're doing right now. And once we figure that out, assuming that we agree that there needs to be potassium iodide in the stockpile, I think we will act on that requirement.
Are you looking at larger radiuses than a 20-mile radius as was outlined in Mr. Markey's amendment?
I think
what the experience in Japan taught us anything there?
I think what we're doing is, taking all of the science into account and taking what we've learned from the recent event and trying to figure out what does it best take to protect the population, whether it's going to be what the exact radius is that we're going to settle on. I think that's going to really depend on what the science shows us.
The potassium iodide itself is a relatively stable compound. I mean, does it really go bad?
Well, we just had that discussion as we looked at shelf life extension for the pediatric potassium iodide that's in the stockpile. And FDA was really a terrific partner with us in rapidly testing the liquid to try to look at its stability over time. I think the stability of the liquid version and the tablet version are different, but we do need to sort out what the shelf life of it is and when it's safe to do the shelf life extension. It sort of highlights the need for some of the shelf life extension authorities potentially.
Well, I remember when in my district in the H1N1 crisis, the FDA released all kinds of outdated antiviral medication, and I was assured by Dr. Hamburg that it was just as good as the day it was minted, and that they were revising some of those shelf life expiration dates on a much more complex molecule than potassium iodide, which is relatively straightforward. Let me just ask you a question. Do you have any concern about the availability of potassium iodide? I mean, it is as I understand it is the only treatment that is currently available for prevention of uptake of radioactive iodine by the thyroid, and particularly in young populations. Are you concerned about the availability of potassium iodide?
Well, I think one of the things that we saw during the Fukushima event was this incredible epidemic of fear in the United States, and there was a huge run on the companies, and so people bought up short-term the available.
Yeah, that's kind of the point.
Supply.
That's kind of the point.
Yeah.
So what we reassure people that we have.
So what we need to do is be sure that we have it where we need it, that it's stockpiled where we need it. There have been plans to stockpile it around nuclear power plants. It's exercised differently in different states. That's one of the things that we looked at.
My understanding is that Janet Napolitano just today released information that was gathered in the Osama bin Laden compound about Al-Qaeda's desiring to infiltrate nuclear power plants in this country and wreak some sort of damage. So this is not just a theoretic concern. If the Secretary of Homeland Security is out there talking about this, then our national strategic stockpile should reflect that level of concern. And really, I urge you to spend some energy on doing that.
Yeah, no, I appreciate that, and I think we all very much appreciate the concern, and that's why we are in the midst, I think, almost to closure on coming up with, the recommendations about how much we should stockpile. I don't think any of us have any question that this is a concern, and I don't think any of us have any question that we need to protect the American people in this way.
Thanks, Mr. Chairman. I'll yield back.
Sure, thanks to the gentleman, and yields to Mr. Pallone for a follow-up.
Thank you, Mr. Chairman. Dr. Lurie, I was going to ask you this before, so I didn't have a chance. I wanted to ask about our current efforts on biosurveillance. As you know, in many cases of bioterrorism or natural disease outbreaks, the first clue is that people seek medical care for their condition, and sometimes the condition may appear like other common conditions and could be missed unless there's a system to detect unique features of the outbreak. And biosurveillance is the ability of our system to detect these ongoing outbreaks, whether natural or man-made. I'm concerned because there was a recent GAO report in December that suggests that HHS should be doing more to provide a strategic plan for situational awareness. So I have two questions. I'll mention them both. In your professional opinion, do we have adequate capabilities for biosurveillance, and what are we doing to enhance these capabilities? And can you tell us how the public health infrastructure relates to the biosurveillance infrastructure?
Sure. Great questions and issues that I think are very much on my mind all the time. I appreciate that. You know, surveillance and recognition of outbreaks is most often something that happens locally. Sometimes it happens through astute clinician who sees something more than once. Sometimes it happens through other surveillance systems that are in place in health departments and hospitals throughout the country. At the end of the day, our preparedness in this country, particularly in this area, is built on the back of strong day-to-day systems. We see around the country right now, because of the economic situation, real threats to public health and erosion of public health capability. So something like 40,000 jobs in the state and local level in public health have been compromised over the past couple of years. So they've been lost. They've either lost or been cut back dramatically.
They lost the jobs, yeah.
So people who lost their jobs are working part-time, and right now, it's often only money that is coming through a public health preparedness vehicle that is holding that surveillance capability together at the state and local level. So when you say, do we have biosurveillance capability and how good is it? We know the techniques, we have the tools, we know what to do, but we have to make it work and be sure it works day to day on a state and local level and doesn't get eroded as we're falling on hard times, because this erosion, at the end of the day, compromises our national security.
I mean, it's true. It's a long time since I was a councilman, but I was at one time, and I remember going over the budget, and it was often the case that somebody would say, let's cut back on, the health department, because, nobody really knew what they did. And also, if you're talking about something that may happen in the future, it's easy to say, well, I don't know if that's going to happen, so why should I deal with the preparedness? I mean, I see that that's a significant problem, but the Chairman Pitts and I were talking about how important this hearing is and how interesting it was, because, you can't take that attitude. You have to take the attitude that, we need to prepare. But it is hard. It's hard from a political point of view, because people, they don't want to prepare for contingencies that may never occur, and it's easy to think that they never will occur. And this is, of course, after the fact, but one of the things that we have in my district is we have one of the 9/11 clinics, people that had sustained, mostly first responders who sustained all kinds of health problems from 9/11. And I watch, when I talk to the people that are in charge of the clinic from time to time, and even today, they're still coming up with diseases and disorders that, were unforeseen or that, manifest themselves years later. So it's just so important, but it is difficult, to deal with this issue and to be prepared. I'm only looking at it after the fact, but obviously when you talk about it before the fact, I think it's even more difficult.
And, I think this reluctance of people to always want to think about the unthinkable, even though it's happened an awful lot since I've been here, is in part human nature, and it's part something we have to work against, but it also, I think, shows us the importance of being sure that the day-to-day systems are really strong, so that the systems that detect your foodborne outbreaks, the systems that detect seasonal flu, the systems that do these other things and function in the background day-to-day to prevent us from infectious diseases and do that kind of surveillance have to be strong if we're going to be able to detect a bioterror event or a new emerging disease. We're working, again, through BARDA on the diagnostics end of this, but there's that whole local infrastructure that has to be on the ground to make this work.
Thank you. Thank you, Mr. Chairman.
Chair, thanks to gentlemen. Also, thanks to witnesses. Excellent panel. Great testimony. Thank you very much for answering our question. In conclusion, I would like to thank the witnesses and the members for participating in today's hearing. I remind members that they have 10 business days to submit questions for the record, and I ask the witnesses to respond promptly to the questions. Members should submit their questions by the close of business on August 4th. This subcommittee is adjourned.